And it's my pleasure to welcome Dr. Sugi Ula, an interventional cardiologist at Bern University and Nagavuya Health Center. Today, we'll be discussing his JACC interventions manuscript reporting the outcomes of transcatheter edge-to-edge repair in patients with primary tricuspid regurgitation. Dr. Sugi Ula, thank you so much for taking the time to join us and share your expertise.
Of course, thank you for having me.
Yeah. First, can you give us a brief background, about the topic, the question that you and the team aim to address, and the population you studied?
Of course, thank you. Tricuspid regurgitation, TR, is a common valvular heart disease that often leads to significant morbidity due to right-side heart congestion. While most cases are secondary, about 5 to 20% of patients have primary TR, which is caused by leaflet abnormality, such as flail or prolapse or restricted leaflet motions. And if you look at guidelines, the surgical repair or replacement has traditionally been considered as the main treatment option for such patients. However, many patients in daily clinical practice are referred late and then often with advanced comorbidity, which makes surgery, of course, high risk. So in recent year, we have a transcatheter edge-to-edge repair TEER, which has emerged as a promising, less invasive option, but mainly for secondary TR. However, its feasibility in primary TR remains unclear. That's why we framed this study. And we aim to assess whether TR could be a safe and feasible, effective alternative for those patients with symptomatic primary TR who are at high surgical risk.
Perfect. I think it's very nice background and an important topic that we don't have a lot of evidence in. Can you share with us the results? What did you and the team find?
Yes, of course. We conducted an international multi-center registry across 10 centers, including in Germany, Switzerland, and also United States. And finally, we enrolled 114 patients with primary TR who underwent TR between 2016 and 2023. And actually, the patients, most were elderly, and mean age was approximately 80. Now, they are highly symptomatic and with over 80% of NYHA functional status 3 or 4. And after looking at echocardiography data, we classified leaflet pathology into 4 types. Type 1 is flail leaflet. Type 2 is billowing prolapse, including Barlow disease. And type 3 was perforation, leaflet perforation, which was, however, not presented in this study, by the way. And type 4 was a restricted motion of the leaflet due to degeneration. And we assessed the procedural success and TL reduction and the follow-up outcome and so on.
How was the TR reduction in general in the primary TR and across these, subgroups?
Oh yeah, actually that was really encouraging. And basically the TL reduction was amazing. 83.3% of patients have achieved TL moderate or less at discharge. And if you look at subgroup, the TL reduction, well, pretty much well, especially in a patient with flail prolapse or billowing prolapse
Mm.
lesions. On the other hand, the TL reduction rate was modestly reduced, like 66% or so something in patients with restricted leaflet motion.
Perfect. And from a procedural, let's say, safety standpoint, where did you see any kind of significant difference compared to, the literature and experience with secondary TR?
Oh, um, um, consistent and to the previous studies, the TIA procedure was pretty much safe, which
Hmm.
demonstrated that in-hospital mortality after TIA was 1.8%. There were no stroke, no emergency surgery, and so on.
Perfect. Excellent. How do you think we should move forward, or what's your takeaway message from this importance analysis?
Oh, thank you. Actually, we also look at 1-year mortality data,
Mm.
and which was also pretty fine, encouraging. And we also demonstrate that the lateral reverse remodeling
Mm,
after treating tear and also their symptomatic relief and during the follow-up. And importantly, this motor survival outcome was comparable to surgical data. I mean, we also integrated multi-center registry data of surgery in French,
hmm
and we conducted a propensity score matching analysis
hmm
to adjust the baseline characteristics and so on. And then finally turned out the 1 year outcome mortality was really comparable between TEER procedure and surgeries. That's why I would say that this study show or suggest that the TEER is a really viable, safe alternative to surgery for patients with primary TEER, especially those who are older or higher surgical risk.
Nice. Excellent. How do you think we're going to move forward? Do you think it's time for more prospective studies or potentially randomized trials?
Exactly, this is a really important point because this study conducted retrospectively, we
Hmm
still need to have a prospective data. Like for example, in this study, the data what the cause of primary TL, like for example endocarditis or retraction or so some of that such data are missing. We need to
hmm
such data, and also after all we need to conduct a randomized control trial comparing a surgery versus TIA procedure, especially for high risk patients.
Yeah, I completely agree, and I think the data that you provided is very nice and comprehensive and kind of sets the stage for the next steps. Thank you again, Dr. Sugiura, for your time. And we invite
Thank you very
everyone to
much.
go over, yeah, to go over the full manuscript. It's going to be published in this issue of JACC Interventions. Thanks again.
Yes.